So every patient that's referred to my clinic in interventional radiology, at baseline we evaluate to see the proportion of those patients who are on statins. And roughly 60% of patients who are referred for either intermittent claudication or critical limb ischemia in our practice are not on statins at baseline. So we ensure that they get on statins promptly and ideally before their endovascular intervention, should they in fact require that. So patients who, that's done in conjunction with their clinical cardiologist or primary care physician, and it's based on what their LDL-C levels are. Ideally, any patient who has symptomatic peripheral arterial disease, the data supports putting them on high-intensity statin therapy at the time of diagnosis of peripheral arterial disease. Well, statin use in peripheral arterial disease is less studied than the role of statins in coronary artery disease. Nevertheless, there are a number of studies that, taken together, have a pretty high level of data to support the use of statins in patients with peripheral arterial disease. And the most recent consensus guidelines from the American Heart Association from 2013 recommend that all patients over the age of 21 who have atherosclerotic cardiovascular disease be on a high-intensity statin to the age of 75 and a moderate intensity statin beyond the age of 75. Well, our understanding of the role of statins in peripheral arterial disease dates back to the concept of plaque stabilization, where there were prospective studies, including randomized studies, that showed that the addition of statins to a patient's therapeutic approach for peripheral arterial disease can lead to the stabilization or slow the progression of plaque in patients with demonstrated peripheral arterial disease. That was followed by the heart protection study from the United Kingdom, which was a randomized trial of over 20,000 patients in whom patients received either simvastatin or a placebo, and it showed roughly over a 20% reduction in major lower extremity vascular events, including amputation. Since then, there's been a large registry known as the REACH registry, and looked at the reduction of statins, both whether or not patients were on statins at baseline or statins at any time, in the reduction of lower extremity revascularization, lower extremity amputation, or worsening of their severity of peripheral arterial disease. More recently, just as recently as the last couple of months, a study compared the use of statins at any level, not stratified by low, moderate, or high intensity statins, on the two outcomes that are most significant, that is all-cause mortality and lower extremity amputation, and found a significant reduction in both of those indicators. And in a multivariate model, the only predictive factor wasn't antiplatelet therapy, which is what we all think of as being so important in this group of patients, but it was whether or not they were on statins. Patients who were not on statins had a threefold higher rate of amputation than patients who were not on statins. I think it's fair to say they're underprescribed. The recent study from the Veteran Affairs of more than 150,000 patients who were tracked through till 2014 and then subsequently after that found almost a third of those patients were not on a statin at baseline, despite being diagnosed with symptomatic peripheral arterial disease. This has been echoed in European studies. So I think as a rule, we need to be more aware of the benefits of statins in peripheral arterial disease. And we need to be more proactive in ensuring that our patients are on and remain on statin therapy. Very high-risk patients should be on the maximum tolerated dose So in other words, a dose that lowers their LDL-C levels by at least 50%. Some patients may not tolerate that regimen due to things like myalgias, but if they can tolerate it, that is the consensus from the available data. Patients who can't tolerate the higher intensity statins should be on moderate intensity statins, and that is lowering their LDL-C levels by at least 30 to 50% from baseline.